Welcome back to the second part of our POCUS crash course. If you missed the first part, just check your inbox. It is always available for you because it's a free lecture. Now we'll turn to another very important pathology that we can detect with point-of-care ultrasound, as a matter of fact with lung ultrasound, and that is pneumothorax.
But before we turn to ruling out this important pathology, we first need to better understand the anatomy of the pleura and the lung and how it appears on ultrasound. If you are using ultrasound to evaluate if the patient has a pneumothorax, you can use either a convex probe or a linear probe, and you place the transducer on the highest point of the thorax, marker pointing cranially, and then we look for two ribs, so rib and rib shadow, rib and rib shadow. Here you see the heart on the left side, and we don't need that much depth, so optimize the depth to approximately 5 to 10 centimeters, and then in a point of care setting just look for this hyperechoic line which resembles the pleural line, and look for lung sliding. So as long as something is moving in this area, you can rule out pneumothorax. You do that on the left side and on the right side as well, and here you see the same image. You have two ribs and rib shadow and the moving pleural line, which is pleural sliding, to rule out a pneumothorax.
Remember, air is always located in the most superior parts of the thorax. So image the patients in the supine position in the most anterior location that you can find. Be aware that there's a muscle that could interfere with your observations, that is the pectoralis muscle, and if patients have breast implants, it's a little bit more difficult to determine whether or not a patient has a pneumothorax.
Exactly, a breast implant, for example, can mimic a pleural effusion or even pneumonia. Let's review the image briefly. We have here rib, corresponding rib shadow, here another rib and rib shadow, and here we can see lung sliding. So this hyperechoic line resembles the pleura. This is intercostal muscle, and here we have the pectoralis major muscle. In this case, we use the specific lung preset. Look how nicely you can see the pleural sliding over here. You also can see an A line. If you see lung sliding like this at the most anterior part of the chest, you basically can rule out a pneumothorax.
But can we rule it in?
In this case, this was a pneumothorax, but you cannot rule it in just because there's abolished lung sliding. You just can rule out if you have lung sliding.
And here's an example where you can see lung sliding, and there's a very small pleural effusion, and then there's two lines. One are horizontal and the others are vertical.
The horizontal lines we have already seen, those are A lines. The vertical lines, it's another artifact, those are B lines. B lines are a reverberation artifact. They always originate at the pleura, and when they're there, you can rule out the pneumothorax. B lines can show an interstitial syndrome. If you have many B lines in one intercostal space, there could be a problem, for example, fluid overload.
And B lines are very important because they indicate that someone might have pulmonary edema or pulmonary congestion, which leads us to the heart.
Let's take a look how we can visualize the heart with our ultrasound machine. For the evaluation of a subcostal four-chamber view, we can either use a convex transducer or a cardiac transducer. Now we'll show you how to do it with a convex probe. Be aware that the marker points to the right side of the patient. So here on the screen, this is the right side of the patient. And we have to adjust the depth, approximately 20 centimeters of depth. And then we tell our patient to inhale. Please inhale. Then we can optimize the view. We need a little bit more gain, a little bit more depth. And here we see a subcostal four-chamber view. The left heart, so the left ventricle, the left atrium, the right ventricle, and the right atrium. We use the liver as our acoustic window.
I always find the subcostal view fascinating because it is also, I would say, the overlap zone between the abdomen and the heart. Now, we also use the subcostal view in cardiology. Let me show you how. I will now also show you a subcostal view. However, I will be using a probe which is called phased array probe. It's a probe we use in cardiology because it has a very small footprint. In other words, a very small aperture which allows us to image from in between the ribs and also from a subxiphoidal position. We have a marker again on the transducer, and this marker will be pointing to the left of the patient. So I'll be using some gel, and then I will place the transducer in the region of the xiphoid, pointing a little bit towards the left to the region where the heart is, and then I will ask the patient to inhale, bitte einatmen, and while he inhales, I will move the transducer upwards until I see all 4 chambers of the heart. This is the left ventricle, the right ventricle, here we have the left atrium, and this is the right atrium. Okay, a little bit of a better view right up here. So this would be the subcostal 4-chamber view. This view is ideal if you want to look at left ventricle function, the size of the heart chambers, and specifically to look at a pericardial effusion.
As a short review, what were we imaging? We were imaging the heart from a subcostal approach. We have seen the left ventricle, the left atrium, the mitral valve, the right ventricle, the right atrium, the tricuspid valve, and we used the liver as our acoustic window.
Be aware that not all patients are easy to image from a subcostal window, especially patients who are very slim might be more difficult, or those patients who have an abdomen which is far above the level of the thorax.
Let's take a look at 2 different patients, 2 different hearts. On the right hand side, we see a subcostal view. Again, the left ventricle, the left atrium, right ventricle, right atrium, and here you see the liver. There is no pericardial effusion at all. On the left hand side, there is a small pericardial effusion, but this is still in the physiologic range.
And I guess all of you will agree that this is a large pericardial effusion. As a matter of fact, we call this pathology swinging heart because the heart is swinging within the pericardial sac.
But there is another structure, another vessel in the abdomen we can visualize with a cardiac probe.
Exactly, and that is the inferior vena cava. Let's see how we can do that. Again, we'll be imaging the patient in a supine position, and we will again first perform a so-called subcostal 4-chamber view. So I will ask the patient to inhale. So here is now the 4-chamber view. I can already recognize the structures here. And I will then rotate counterclockwise, pointing the transducer a little bit more to the left. And all of a sudden, I will see a structure appearing right here, which is the IVC. This is the IVC as it enters here into the right atrium. Can you exhale? Yeah. If you look at this vessel, you will realize that there are fluctuations in the size of this vessel, which are related to respiration. Now, here are 2 examples of patients who have different sizes of the IVC. The one on the right definitely has an IVC which is massively dilated. This dilated IVC does give us a lot of information. Anesthesiologists use it to determine what the fluid status is. You will see it in patients who have right heart failure or patients who have maybe massive tricuspid regurgitation. On the left-hand side, you see a completely normal IVC. Again, note how the size of the IVC fluctuates with respiration.
One of the most important questions in point-of-care ultrasound is, how is left ventricular function?
Exactly. It's so important in so many settings, and we talked at the beginning about the symptom of dyspnea. Now, before we talk about left ventricular function, we need to learn another view which is very helpful to determine how ejection fraction and function actually is. I will demonstrate a view to you which is not really part of the FESC protocol, but a view that is very important if you want to assess left ventricular function. And that is the 4-chamber view, a view that we in cardiology use very, very frequently. How do you obtain the view? Well, you place the patient in a left lateral position, And you ask the patient to raise his left arm, and then you place the transducer at the apex, pointing the transducer towards the shoulder, towards the right shoulder, and then you would obtain a view which looks like this. What structures can you see? The left ventricle, the right ventricle, the left atrium, and the right atrium. You will see the myocardium with the septum here, and you will see the mitral valve and the tricuspid valve. Of course, you can also use color Doppler here, which will be very helpful if you want to assess if a patient has severe mitral regurgitation.
Let's review briefly what we just saw. We saw an apical 4-chamber view. We saw the left ventricle, the left atrium and the mitral valve, the right ventricle, the right atrium and the tricuspid valve.
And here is a 4-chamber view. If we assess left ventricle function, we'll be looking at several things. Importantly, we'll be looking at the so-called inward motion of the endocardium. You see that all the different segments are moving to a center. On top, we also see that the level of the mitral valve is moving towards the apex. That's exactly what we'll look at when we assess left ventricle function. Here are two patients. The one on the left is the one we saw previously with normal left ventricle function. On the right-hand side, a patient with dilated cardiomyopathy. Note that the patient on the right-hand side has a very large ventricle and that the entire myocardium is hypercontractile. I guess it's very easy to tell that one is better than the other. And this is also what we find in the literature. With point-of-care ultrasound, we visually assess left ventricle function, and we are able to differentiate patients with severe from those with normal ejection fraction. But there are other pathologies we can detect as well, especially if we add color Doppler.
What we can see here in this case is severe mitral regurgitation. You see a jet over here, a liasing, so the rapid change in red and blue color.
Be aware though that color Doppler is not part of an EFAST exam, but you can definitely use color if you have some of the machines that we've shown you previously.
And it just gives you additional information, especially in this patient. This patient has poor left ventricular function and still more volume overload due to mitral regurgitation.
But there's more you can see in a 4-chamber view, and here's an example of a patient who has massive left ventricular hypertrophy.
You see that the chamber of the left ventricle appears to be rather small, but function is still normal.
Exactly, and if you look closely, you will notice that the left atrium is also very, very large. This is a patient who had severe hypertensive heart disease. Now let's take a look at another patient that demonstrates that you can compare the size of the chambers to each other. For example, here you will see that the right ventricle is significantly larger than the left. This points to a right heart problem. Again, a very important feature that will help you to determine why, for example, a patient has dyspnea. In this specific case, the patient had very severe tricuspid regurgitation, which led to dilatation of the right ventricle. Of course, we're only touching on the topic of cardiology and the potential to use ultrasound in point-of-care ultrasound. We need to move on though. We need to move on to another cavity.
Let's take a look at the Douglas or Bruce cavity, so the lower abdomen. Let's see how this is done in a demo. To scan the urinary bladder and the Douglas or Bruce cavity, we have to place the transducer in the lower abdomen. Marker is pointing towards the right side of the patient, and we tilt the transducer caudally until we see an entirely echo-free space. That's the bladder over here. Normally, you should evaluate the bladder when it is really full, so it should contain approximately 300 to 500 milliliters. In this case, it is not entirely full. We always have to scan the bladder in a transverse view, like now, and also in the longitudinal plane, moving the transducer that the marker points cranially. Here again, we see the urinary bladder. For free fluid, you would look in this case to the Bruce cavity, so below the urinary bladder and the rectum.
I find imaging the bladder fairly easy.
Tommy, you're absolutely right. It's rather easy, but did you know that you can use color Doppler in scanning the bladder?
Well, I assume that you're going to show us an example.
Of course, here you can see urine entering the bladder. And you can visualize this with the help of color Doppler. We saw color Doppler in cardiac ultrasound. You of course can use it in abdominal ultrasound as well. If you see urine entering the bladder like this, you can be quite sure that there is no complete obstruction of the urethra.
But isn't there something else that ultrasound of the bladder can help you with? What about urinary retention?
That's a very good point. Let's see Amanda. Amanda has terrible abdominal pain. To be exactly, lower abdominal pain. Let's use point of care ultrasound. And what do we see immediately? We see a huge bladder. On the left side we see a transverse view, and on the right side we see a longitudinal plane.
How much urine do you think was in the bladder?
To be honest, I know. We placed a catheter and we got out 1,800 ml of urine.
We can actually perform measurements and calculate the true volume of urine in the bladder. But this is something which is probably more for the advanced. At this point, it's important for you to know you simply have to place the transducer on the bladder and you can easily detect urinary retention. Good, we're not through yet because we have several organs that we want to show you. The next one is the gallbladder.
To find the gallbladder easily with ultrasound, you have two options. Either you start on the right side of the patient and move towards the midline, or you start at the midline and you move towards the right side of the patient. Always keep the lower margin of the liver in your field of view and then move to the right side of the patient, and all of a sudden there will be an echo-free organ. Can you please inhale and hold your breath? As the patient inhales, we get even a better view of the gallbladder and the whole extent. Also scan it in a longitudinal and a transverse plane.
So you see, it's quite easy to find the gallbladder. There's one situation where it is more difficult, and that is if patients did not fast. Because after meals, the gallbladder just shrinks and you might have difficulty to find it.
Exactly, and when the gallbladder is really small, you also can think that there is cholecystitis present. But first, let's review this loop again. Here we see a normal gallbladder, the wall is thin, and here we see the liver. Now, let's find out what kind of pathologies we actually can see. This one is quite straightforward. Do you see those hyperechoic areas? Those are all small gallstones, small pebbles with acoustic shadowing. Here's another more severe pathology, that's cholecystitis. What you can see here quite nicely is that the wall is definitely thickened. You have a gallbladder filled with stones, and this patient had a so-called positive sonographic Murphy sign. So you just place the transducer, you press, and if the patient feels pain, that's a positive sonographic Murphy sign.
So these were two very important pathologies that we can detect with ultrasound. But if we move the transducer just a little bit more to the midline, we'll see a structure which is even more important, especially with respect to fatalities which can occur if we do not find a very important pathology, and that is the aorta.
Well, let me show you how to image the aorta. To visualize the aorta, make sure that you place the transducer really just below the xiphoid to get the optimal view. You can also again tell the patient to inhale, but his image quality is terrific. You also can exhale and then tilt the transducer more towards the left, and then in the center you see this big vessel, that's the aorta. How can you be sure? If you tilt it more towards the right side, we see another big vessel, that's the IVC. So to the left side, you see really nicely over here the aorta and the celiac trunk. Can you inhale please? Terrific, please hold your breath. Celiac trunk over here and the superior mesenteric artery over there. In this example we see a normal aorta. This is the vessel over here. We see the celiac trunk and the superior mesenteric artery over here.
One of the most important things to do is to look at how wide the aorta is. The cutoff value is somewhere in the range of 25 millimeters, so here we have a completely normal aorta. A very comforting finding. In contrast, here's a patient where we need to be worried. Why? Because we see that the aorta is a little bit widened, but that is not the main problem. We see a membrane within the aorta, and that is what we call a dissection membrane. This patient has aortic dissection. Here it is sometimes quite helpful to also use color Doppler, because there you can sometimes see the leakage between the so-called false and the true lumen. And you can differentiate between the true and the false lumen based on the color Doppler pattern. But the bottom line is that this patient definitely is at risk and that something needs to be done about this pathology. And here's another patient, a patient who was actually on the ward because he had a myocardial infarction. And when we moved the transducer to the abdomen, we saw that there's a huge aneurysm. As a matter of fact, a part of the aorta was filled with thrombotic masses. In general, always look at the pulsatility of the structure, because the strong pulsatility indicates that it is the aorta. You should not mix up the aorta with the IVC. If you follow the EFAST protocol, you're going to cover a lot of pathologies, but there is much more we can do with ultrasound. Maybe not part of the standard protocol, but even more important now in the situation we are in with COVID-19 infection. Let us show you some examples and discuss how ultrasound can be used in this setting.
The first patient we want to show you is a COVID-19 suspect. Of course, we tested him, but before the PCR results were available, we also performed point-of-care lung ultrasound. And what we could see was a completely normal scan. So we didn't see any B-lines or other artifacts or consolidations. And also, after all, the PCR turned out to be negative.
So you see, ultrasound does have its place. Of course, we can never be sure that the patient is not infected, but it gives us a lot of information whether or not, for example, a patient has pneumonia at the moment, and also what the severity is. But what are the typical findings that we would see in a patient who does have the typical COVID infection?
This is a case from our dear colleagues in Italy. In this patient, you can see B lines. That's a very important finding. We have to be aware, nothing we see is specific, but if we have a patient and the clinical picture, it's very suggestive. So B lines, remember these vertical artifacts. We have a somewhat irregular and thickened pleura and small consolidations over here. The same we can appreciate in the next image. We have a thickened pleura. You have the feeling that lung sliding is reduced, and also these vertical artifacts can be seen, and additional, some really small consolidation areas.
But where can lung ultrasound be used in the setting of COVID-19 infection? Well, one of the major problems with the infection and pneumonia is that we see vascular leakage. We see fluid moving into the lungs, and that's also why we have these B lines. Now, the amount of B lines probably corresponds in some way to the amount of fluid which is in the lungs. So the information we get from lung ultrasound gives us not only information about the severity, but probably also about the prognosis of patients. Of course, many of these things need to be shown in the future. In any case, if you have a patient who has pneumonia or suspected pneumonia and COVID infection, it's very difficult to use CT. CT is probably not the first-line diagnostic tool to determine whether or not a patient has pneumonia or not. So lung ultrasound has a very prominent role. It's probably the primary diagnostic imaging tool in the setting of COVID-19 infection.
Aside from the very important indications for lung ultrasound in COVID-19, point-of-care lung ultrasound can be used in so many situations. Can be used in ICUs, can be used by GPs. You can see very many pathologies.
Well, I can only agree, and I can only hope that you will find some fun in learning ultrasound, learning point of care, and I'm sure that if you do, you will be very, very much rewarded.